Hi, I'm Dr. Robert Berry, and I'm the Medical Director of Orthopedic Sports Medicine at Baylor Plano Regional Medical Center in Plano, Texas. In this presentation, we're going to talk about common hip and knee injuries that we see in gymnasts. Hip and knee injuries in gymnasts is almost an epidemic when you look at these athletes. 69,000 children under the age of 14 were treated in hospitals, doctors' offices, and clinics in 2007 when we look at the injuries seen in gymnasts. This according to the U.S. Consumer Product Safety Commission. What are the most common injuries that we see in gymnasts? Well, anterior cruciate ligaments are very common. We see a lot of patellar tendonitis or overuse injuries. Patellofemoral syndrome, which kind of encompasses a variety of diagnoses, but essentially pain resulting from the kneecap articulating on the lower thigh bone or the femur. Hip injuries, impingement of the hip, tendonitis of the ankle or the Achilles, and sometimes ruptures. When we look specifically at knee injuries, it's often 8 to 14 times the body weight when we consider the amount of force that the lower extremity has to absorb. And so these types of activities that are done, such as on the vault, can cause tremendous amount of force. The jumping and impact do cause tremendous force on the joints. So what happens when we jump and do these types of impact activities? Well, it certainly can injure the cartilage in our knee. When we talk about arthritis in older individuals, usually arthritis is a result of things that we do when we're younger, kind of like a crack in the foundation, much like one in our house or in the sidewalk in front of our house. A small crack after years becomes a very large one. We're only born with a certain amount of cartilage, and when that is damaged, it doesn't heal very well. The blood supply is very limited to cartilage, and as we get older, almost non-existent, period. So what happens is that the cartilage actually acts as a shock absorber, and as we get older, or if the cartilage gets damaged, it actually loses some of its water content and its shock absorbing effect. This is a busy slide, but essentially just showing that tibial cartilage damage and deformation at peak displacement compression during simulated landing impact. So essentially what's happening is that showing in this particular study that the cartilage deforms when we impact, such as jumping off of a vault, doing a round off back handspring. All these types of impacts certainly can cause significant amount of force, and this will contribute to significant cartilage damage, fissuring, and then ultimately propagation of the fissuring to actually full-blown arthritis later in life. ACL injuries, many people have heard about, but essentially female gymnasts are at the highest risk compared to our soccer players and basketball players, which I see a lot. There's some evidence that the elevated estrogen or hormonal levels in females causes joint laxity, which can increase the risk. Females actually fire their hamstring muscles slower, which also increases stress on the ACL. So when one lands, instead of using our legs as a shock absorber, females tend to use their legs more as a jackhammer, landing rigid, and this puts increased force on our knees. If you do injure your ACL, you need to have it fixed. We know from long-term studies that without fixing an ACL, you're very likely going to develop arthritis later in life, and the chances of you being able to return to gymnastic sports or multi-directional activities are going to be very challenging if you can do at all. I always tell my patients that the ACL is kind of like the seatbelt of the knee, and if you're going to back your car out of the driveway, you may not necessarily need to put your seatbelt on, but if you're going to do sporting activities, and if you're going to be driving a car down a tollway or down the freeway at high speeds, you certainly want to have your seatbelt on, because if you had to slam on your brakes, you'll end up in the windshield or the steering wheel. And the ACL essentially is what allows you to change direction rapidly and do what we would call athletic moves. So without that ACL, you will not be able to do that. And one of the things that is a misnomer is people think, well, that they can wear a brace and simply brace an ACL. But even the best of braces will not necessarily prevent damage or injury to the ACL, and certainly can't prevent the micromotion that will go on in the knee. So when you talk about fixing an ACL, you are actually referring to reconstructing an ACL. You can't necessarily go in and actually sew an ACL back together. So that means that you actually have to use grafts or tissue in order to reconstruct the ACL. And there's different types of grafts, and you can use your own or donor, sometimes referred to as cadaver graft. Hamstring or kneecap tendons are a popular autograft or using from oneself, and there's many other types of donor or allografts such as tibialis anterior or Achilles or popular grafts, hamstring grafts, allografts as well. So this is an illustration showing one of the most common types of graft, and that is the middle third of the kneecap tendon. The benefit is your own tissue, and it certainly is strong and incorporates rapidly into the bone tunnels. But sometimes people will have pain when kneeling, and that can actually be problematic. Other individuals may actually be at risk for fracture, and this has injured some athletes' careers. I had an individual that worked for me who had another orthopedic surgeon do his knee surgery many years ago, and after rehabbing was running to first base and had his patella fracture. So you can see in the illustration there where a piece of bone is taken from the kneecap and the tibia, and so that certainly creates a stress riser for potential fracture. So we know that there's not necessarily a ideal graft, and if there were, we would be using it. So we certainly consider our athletes or consider our patients, and then with their input and what we would call shared decision making, try to select a graft that's going to be best for them. Patellar tendonitis is certainly something that we see a lot, and that is an overuse injury, often pain in front of the knee. Usually it responds to rest, but unfortunately many of my patients, especially gymnasts, do not want to or cannot, especially the higher caliber gymnasts, take time off. So we talk about ice, massage, we use a kneecap strap, rest, and topical anti-inflammatories as well as oral anti-inflammatories combined with an appropriate rehabilitation or physical therapy program can be quite helpful. Osgood Schlatter's is a very specific condition which causes some fragmentation or partial avulsion of the kneecap tendon's attachment to the upper leg bone or tibia. Caused by repetitive jumping, it's actually more common in teenage boys than girls. Usually you see on x-ray some fragmentation or what we would refer to as an ossicle, and the treatment is rest, ice, this what we call CHOPAT, C-H-O-P-A-T strap or patellar tendon strap, and quad strengthening. Kneecap tracking problems are very common in females, and mostly because of their wider pelvis, we develop a knock-kneed or valgus appearance. They often will have weak quads or what we call vastus medialis obliquus or VMO for short imbalance, and often can be a shallow groove where the kneecap tracks. So just much like your car tires on your car, if they get out of alignment, then they're going to wear abnormally or rapidly, and without doing corrective alignment, then you can end up with severe arthritis. When we look at the list of these things, the only thing that we can really change is actually our quad imbalance. So working on strengthening physical therapy is something that can be done. Here's a paper that was done looking at proximal strengthening program, and we see if we look at the highlight area that an 8-week rehabilitation program focused on strengthening, improving neuromuscular control of the hip and core muscle produces positive patient outcomes, improves hip and muscle core strength, and reduces the knee abduction movement, which is associated with developing patellofemoral syndrome. Hip pain. When we talk about hip pain in athletes, first we have to define what is the hip. Often when patients come in, they point to a variety of areas when they talk about hip pain. So is this the hip? Or is this the hip? Maybe here. Well, this is actually when we talk about hip pain what we're referring to, and that is pain in the growing area. There's many sources or causes of hip pain. We can talk about tendonitis. We can talk about the snapping hip syndrome or pain around the hip that pops. Talk about a specific condition called impingement syndrome. And these are all things in this illustration talking about the tendonitis or the popping that can occur. We talk about the impingement, and we have what we call a pincer lesion, or we can have a cam lesion. And these are bony prominences in the hip joint which can impinge, hence the name impingement, and cause significant pain. So like many things, the initial treatment of hip pain is simply rest, rehabilitation, anti-inflammatories, or as we would say, punt, meaning that if you're not getting better on your own, then see an orthopedic surgeon who specializes in these types of problems, especially if there's been a history of trauma. So there are many causes of hip Snapping hip syndrome, usually it's of no consequence, and it's a result of tendons actually sliding or gliding over bony prominences. And specifically, it can be our hip flexor, which pops over the femoral head, or it can be our IT band with the gluteus maximus tendon sliding over the greater trochanter with knee extension, meaning straightening the knee, and hip adduction, or moving the hip towards midline. When people have femoral acetabular impingement, or what we call hip impingement for short, usually it's true hip pain that's not improving with rehab, and that's the pain that is in the hip. And often people will present reporting this C sign, just like this patient in this illustration in the blue scrubs is pointing to. Usually there's relief with anesthetic injection in the hip, and if it's not improving with conservative treatment, then often we will consider hip arthroscopy, and what we do a resection of the bony prominences. Labral tears can be caused by hip impingement or can be isolated, and it's something that can be sudden, or it can be something that occurs over a long period of time, such as impingement. Usually MRI with or without contrast can be helpful in order to diagnose these. Usually it's somewhat of a diagnosis of exclusion, a hip pain that's not responding to conservative treatment. It's not received much relief permanently with diagnostic injections, although it may be temporary relief, and so then we talk about doing a scope. This is what we often will see when we go and scope a hip, and that is a labral or cartilage tear. And this is another arthroscopic image looking at the hip and the damage done in impingement. And what happens essentially is it's the bony prominence that pinches on the cartilage in the hip, and it causes damage over time. And so this is what will lead to early arthritis. And this in this lower illustration is showing that where the hip flexes up and it pinches, and so if there's actually a cam lesion, which is a bony bump on the femoral head or neck region, it'll pinch the cartilage, or a pincer lesion, which is bony prominence on the socket side, which can pinch the labrum between the femoral neck and head junction. So when you do the procedure, this is what you do, and this is an arthroscopic picture of a patient looking at specifically the resection that's been done. And the lower illustration, the L representing the labrum, the FH, the femoral head. And so, and you look back up at that upper illustration, you can see the bone that was taken down. So the take home on hip pain is if an athlete has chronic hip pain and isn't responding, then an orthopedic surgeon should be involved to rule out true hip pathology and treatable sources. You certainly want to manage the athletes and the family's expectations early. I think if this is something that may require surgery, you want to have that discussion so that everybody is on the same page.
Away, I'm just a breath away, losing my faith today.
I'm falling off the edge today.
I am just a man, not superhuman.
I'm not superhuman.
Someone save me from the hate. It's just another war, just another family
I'm
torn.
falling from my feet today.
Just a step from the edge, just another day in the world we live. I need a hero to save me now. I need a hero.
Save me now.
I need a hero to save my life. A hero will save me.
Just in time.
I've gotta fight today to live another day. Speaking my mind today.
My voice will be heard today.
I've gotta make a stand, but I am just a man.
I'm not superhuman.
My voice will be heard today. It's just another war, just another family
My
torn.
voice will be heard today.
It's just another kill. The countdown begins to destroy us. I need a hero.
And the bottom line with that is that you can come back, and that's why we show those injury slides and video, and then to show that you can make a comeback with the appropriate care and intervention. And so oftentimes when we deal with these injuries, people think that they will be career ending, but usually we can get people back. So what to do if you're hurt? Well, fortunately, it's one of those things where you want to tell somebody. Often we want to hide injuries because we're afraid that we may be taken out of an event, or a coach may prevent us from competing. But it's important that we recognize injuries early, so that, as our grandmother or our moms told us early on, an ounce of prevention really is worth a pound of cure. Rest in the ice can fix a lot of aches and pains. I apologize for the slide and how it's showing up here. But certainly if you aren't getting better, then see a sports medicine specialist and know who's on your team, your coaches and your team, your parents, athletic trainer, and doctor, and we're all here certainly to help. So when we talk about gymnastics, the commitment, the sweat, the hours, the time in the gym, we often say, is it worth it? Well, I think that the proof is in the pudding, as one would say, and I think that if you were to ask these young ladies, that sweat, sacrifice, and hard work, that nothing comes without that. And I think that these young ladies here would certainly tell you that it was well worth it. So thank you. I hope that you found that helpful. And certainly you can visit us on drrobertberry.com. That's DRROBERTBERRY.com for further information. Visit our website. We have other resources for you. If we can be of any service, we hope that you will visit us. Thank you.